Yeah, that's what I was thinking. All right, well, good morning, everybody. Welcome to those of you in the room, and welcome to those of you remotely. We have, I see two participants at King Drew. Is that correct?
Oh. Sound on.
Yes, that's correct. Hi, I'm David Gordon.
Hi, Sherry. Shimi Hara here. I go back when Rick Brown was still director.
Okay.
Yes. Me too. I was with the center from the beginning, so we still miss Rick. Well, thanks for joining me today. And so we'll be together for 3 hours. I'll be talking about economic evaluation of health technology. In honor of the memory of my another deceased colleague, Tony Yancey, who was a firm believer in something she called instant recess and pioneer in that. We'll be taking 2 breaks during the 3 hours. I'm not going to sit here and talk for 3 hours, and I'll try and space it so that it's about every 50 or 60 minutes. But basically today, what I want to do in the first hour is talk about the motivation for economic evaluation of healthcare technology. And I'm going to spend a little bit of time. I'm not going to go into a lot of detail, but I'm going to try and set the stage using an economic framework because, after all, this is economic evaluation. So I'm going to use some economic terminology and basically try to motivate why is it that we do this? Why are we even having this session? And I'm going to contrast it with what happens in other sectors of the economy and why we don't teach this for other sectors. What is it that's unique about healthcare that we have to even have a session like this, and why is this important? And then I'll talk about the different techniques in a very sort of general way and distinguish between the 3 major techniques that are used to do technology assessment. After the second hour, we'll focus a little bit more detail on those techniques and specifically cost effectiveness analysis. And then I'll walk you through a relatively simple example of a cost effectiveness analysis from the literature. In the third hour, what I want to do is spend some time talking about the general framework for doing cost effectiveness and the different kinds of applications of cost effectiveness, but in a more generic way, in a sense, a more generic framework. How do we do a cost effectiveness when we're looking at preventive services? How do we do it when we're looking at alternative treatments, et cetera, et cetera? And the purpose of that last hour is to show you that, in a sense, the framework is virtually the same regardless of the problem that you're applying it to. And I want to sort of the major takeaway message there is that once you sort of understand how to frame these problems, you can apply them to a multitude of settings in healthcare as well as outside of healthcare. So that's sort of a map of what I'm going to be covering over the next 3 hours. So let me start by talking about why is it that we do this. And I think that the first thing we need to do is start with the definition of what is healthcare technology, because I'm a firm believer that all of us have this common sense notion when we're talking about health technology that first thing that comes to most people's minds would be either the big ticket items that you'll see across the street in the medical center, that's technology, right? It is those machines, the MRIs, the CAT scans that we've developed, and the high ticket things that we've produced. And, we could also say, well, pharmaceuticals fit into that as well, because that represents sort of cutting edge science and technology. And of course, all of that's correct. That is part of healthcare technology. But what I'd like to suggest to you is that that's the narrow definition. So yes, technology in healthcare is medical equipment, it's devices, it's drugs, and it's all of the techniques that we use for the diagnosis and treatment of diseases. But what I'd like to do is really encourage you to think about technology assessment more broadly. And this also is consistent with an economic framework. Broadly defined, healthcare technology involves all types of healthcare interventions, including public health programs, health promotion and disease prevention programs, and even things like changes in the mix of providers, because the fact is the production of healthcare services, if we think about it in sort of a manufacturing context, and I don't want to take that analogy too far, but you can use a different mix of providers to achieve the same goal. Maybe we don't need a consult with a physician to encourage people to quit smoking. Maybe talking to a health educator would be a more effective way to encourage somebody to stop smoking. And of course, that health educator is going to be a much lower cost and as a result, less costly way to achieve the same goal. So I don't want to get trapped into thinking about technology assessment as trying to figure out what is the most cost-effective way to treat heart attack patients, because that is, in a sense, too narrow. And I certainly personally have been involved in a lot of cost-effectiveness studies over the years where we've looked more broadly at public health interventions, programs, and those are legitimate examples of health technology or public health technology. So why even bother with this? I mean, why am I here today talking about this topic? I will guarantee you that there is not a technology assessment course being taught in most other professional schools on campus. We wouldn't see this class in engineering. We may or may not see something like this in the business school. But the fact is that what I'd like to do is set the stage that the reason we do technology assessment in healthcare is because markets in healthcare don't work the way that they do in other sectors of the economy. And my slide, I'm going to talk a little bit about cars as an example and contrast that market with, but the other one is this thing that we all have, these iPhones and smartphones, even if you don't have the Apple brand. Who's done a technology assessment of these? Is anybody on campus studying whether this is more cost effective than the brick phone from the original mobile phone that looked quite literally was a brick? It was like my coffee cup. Did somebody in the business school do a study and say, well, wait a minute, the brick phone has some advantages. It feels more sturdy in my hand. It won't slip as easily. Maybe this is more cost effective than this. Nobody's done that study. The market has figured out that, and actually, I didn't have to read a journal article or need a PhD to figure out that this was better than this, pretending that this is the brick phone. It's almost intuitive that this is a better product. But the fact is the market sorts that out in most other segments of the economy. Why doesn't that happen in healthcare? Why doesn't the market figure out what the best way of delivering healthcare is, what the most effective and the highest value service is? Well, I'm going to talk a little bit more about that in the next few minutes. I want to sort of set the stage for answering that question. But, you know, we can look at the market for a product like an automobile. And so when we want to purchase a car, we might be interested in information like what's the price? So what's the purchase price? But anybody who's bought a car knows that it's not just what I pay up front, it's what is the ongoing operating expense. So if I expect to own the car for 5 years, how much is it going to cost me on an annual basis? And that's related to the issue of reliability. But reliability you could also separate as a distinct, if this car is going to break down frequently, even if it doesn't cost a lot to repair, it might take a lot of my time. I don't have time to go and get this car fixed. I don't have time to worry about whether it's going to get me to my destination. You know, I had a car when I was in high school that was a used car, and I worried every time I got into that car whether I was going to make it to where I was going. there was always a probability that this car was going to break down on the side of the road. And I'm sure that there are hundreds of thousands of people in Los Angeles who have that same experience every day. The best car that they can afford is one that's not reliable. But I also might be concerned about the safety of that automobile as well. And in fact, I think we can all thank Ralph Nader for making this a national concern by writing a book almost 50 years ago called Unsafe at Any Speed. The fact is that Nader called attention to the fact that that cars were killing people. They were not safe, and that they were inherently unsafe in their design, and as a result led to unnecessary and preventable death. So these are all things that we might be concerned about. I've already suggested that in most markets, technology tends to produce lower cost so that consumers receive higher quality products for lower prices. That's certainly true of automobiles. Now we know that, over the course of the last 40 years, because of technology improvements, the price of cars has gone up. But in real terms, taking into account the improvements and the safety improvements, the costs of automobiles today are not really that much higher than they were 30 or 40 years ago. So what we've seen is a dramatic increase in quality, reliability, and maybe most importantly, safety of cars without this tremendous run-up in the price of cars, because competition has worked in that marketplace to drive producers to develop cost-saving or cost-effective innovations. But in healthcare, technology often, not always, but often tends to produce higher costs, and the improvement in health outcomes may be uncertain. So the point that I'm emphasizing here in a sort of more general economic framework, because we're talking about economic evaluation, and why am I teaching this class today, is that competition doesn't always work in healthcare markets to produce better products for lower costs. It can, but it doesn't always, and it often produces better quality, but at a much higher cost. Again, in contrast to even a market like automobiles or these phones. And this is not a cheap phone if you have to pay the full price, right? But boy, does it do a lot. It's pretty amazing. So, in contrast to, say, the market for cars, what might we as individuals be interested in when we're purchasing healthcare? So, if competition works in other markets, why isn't it working in healthcare? So, well, as individuals, we might be concerned about the price of the service, but actually if I ordered this in or listed this in the order of importance, price might be the last thing that we think about in healthcare. And why is that? Well, because healthcare services are extensively insured. And we know that not every American has adequate health insurance, despite the Affordable Care Act and our efforts to expand insurance to all Americans. But the fact is that the majority of people have insurance, and as a result, price may be the last thing that people think about when they're buying health care. But the quality of the provider, now that is probably a very important consideration. How good is my doctor? And if I need elective or urgent surgery and actually have time to shop around for a provider, how good is that specialist? How good is the quality of care that they provide? I might be interested in the effectiveness or the appropriateness of the service. Do I really need this? I might trust my doctor, but I also might be skeptical. And if there's a risk of mortality associated with the treatment, my concern about the appropriateness and the effectiveness now is going to be heightened because there's something at stake. But even for more minor procedures, I might be concerned about the appropriateness. I know every time I get a recommendation to get an MRI, I scratch my head and say, is this really necessary? Are we really going to learn something from this MRI? Because I know that my doctors always feel very free to write that order, even in an HMO. And I'm always the one who's skeptical and saying, really? Do I really need that? But the other thing I might be interested in, and again, it depends on sort of the severity of my condition. I might be interested in what is the likely outcome, and what's the outcome if I get the treatment versus the outcome if we do watchful waiting, or if there are 2 or 3 treatments, what are the likely outcomes for all of those possibilities? So if this is the kind of information that's important to me as an individual when I'm out there in the healthcare marketplace, I'd say that this information has value. And it has value, strictly speaking, in an economic sense. It means it's an economic commodity. Information is a good. And if a good has value, then we could actually put a price on it there, and it's subject to, sort of supply and demand. So if we as individuals would like to have this information, then the question I pose, and the 2 questions here is, do we have ready access to all this information? If not, why not? And then an additional question is really not just who needs this information, but who else needs this information. In other words, is it just valuable to me, or would this information be valuable to other actors, other stakeholders in the healthcare delivery system? Well, before I go to the next slide, let me just pause here and I'll pose it as a question. Where do we get information like this? So I've got 4 items up here: appropriateness or effectiveness, outcomes, provider quality, and prices of healthcare services. I used to have a challenge for my students back in when we actually had more print material. I said, I can give you $5. You can walk down to the newsstand in Westwood, which the last time I was by, I'm not sure that it's still open. It might be. But you could buy several magazines on that newsstand that would provide information like this for if you were buying a car. And the fact is that now you don't have to go down to the newsstand because you can look it up on the web. All those magazines have websites now. But if we're interested in buying a car, we can get a lot of the information that we might be interested in. Consumer Reports, April edition, is always about automobiles. Price, reliability, safety. And they have a star rating system. What's the equivalent for healthcare? Well, the answer is that we're starting to get there. That kind of information is starting to be available, but not for all of these dimensions. Quality/patient satisfaction data is available from several websites. Effectiveness and appropriateness of services, that's a little bit more difficult. The United States Preventive Services Task Force does a rating of the scientific evidence about the effectiveness of preventive services and assigns a letter grade. And under the Affordable Care Act, preventive services that receive where the evidence is rated as A or B must be covered by law at no cost. So there is some information, and there's actually a rating system for those. For the effectiveness, the appropriateness, not. The assumption there is that the appropriateness is using the stated guidelines. But what if my doctor tells me I need a bypass graft surgery? Where do I get information about the effectiveness or the appropriateness of that easily?
Dr. Google.
Well, yeah, that's right. You can Google. You can Google. I'm not sure that there's a website that has that information neatly summarized for us. Although in California, there have been reports on bypass graft surgery produced by the state and I think the California Healthcare Foundation, if I remember correctly. The point is that this information is becoming more readily available, but it's not quite as you need to do a little bit of searching. There's not, in a sense, one place where you can go to find it all. And you might need to have some, specialty training to understand and to be able to interpret the data. Again, I didn't need to read a journal article to know that this was a better product. And I didn't need a PhD or special training in the electronics or any of the components that went in to build this. It's useful, I know it, it does what I need it to do, and I can assess that without a degree. The question is this kind of information readily available in a way that my mother could understand it? Assuming my mother could actually access and use the internet, which is a separate issue. So the question is, or the point that I want to just summarize is that this information has value. It is being produced, and it's becoming more readily available. But we're still not at the point where where we have the equivalent of a consumer report, where we can get all of this information about the care or the services or the providers that might be relevant to our situation. And with the price of services, that is probably the least available piece of information still, although we're making progress in that area as well. Now, I'm not going to spend a lot of time on the next few slides. This is going a little deeper into the economic framework and uses economic jargon. So I'm not going to go into this because my goal today is not to turn you into a health economist, but just to summarize and to build on the foundation here, again, that these techniques are founded in economic theory, and so I just want to go, in a sense, a little at a superficial level. The fact is that in economic theory, there are four major sources of market failure that keep markets from functioning properly. And my message to you today is that healthcare markets don't function properly. They're subject to essentially all of these problems that are listed here. So when there's market power either on the buying or the selling side of a market, that can cause markets not to function properly. If there's incomplete information in the marketplace, then markets don't necessarily function properly. If there are what are known as externalities, and externalities are really important, especially in public health, then markets don't function. And the best example I can give you of an externality is cigarette smoking. Why is it that we have laws to prohibit cigarette smoking in, say, this building? Well, it's because of the scientific evidence that if I sit here and light up a cigarette, you're also breathing in that smoke. And the health consequences to each of you is almost as severe as to me, as the person smoking. And yet, I'm old enough to remember being in college and cigarette smoking was allowed in the classroom when I was in college. So we've seen it literally a sea change in the thinking about that issue in the last 30 years. And frankly, it's a change that happened much faster than many of us ever thought would. But that's a classic example. The other is the reason why we have catalytic converters on automobiles, because that air pollution coming out of the tailpipe of your car isn't just something that affects you, it affects all of us. I can't separate out the negative consequences so that if you don't want a catalytic converter, you're the only one who suffers. All of us suffer when you don't have one of those. And then the final one is what are known as public goods. And you might say, well, look, aren't we, when we're talking about the public, essentially everything is a public good. In this context, the economic definition of a public good is more narrowly defined. It's defined as a product or something that once you produce it, you can't easily prevent or exclude others from benefiting. So in a sense, it's a positive externality. One example would be national defense or security. I might decide that I don't want to pay taxes for the military because it's against my beliefs. But that's a good that once it's produced, everybody benefits. You can't easily segregate out who's benefiting and who isn't. So again, I don't want to spend a lot of time on this, but I just wanted to show you some of the examples of why healthcare markets fail and how these 4 causes of market failure apply in healthcare settings. And again, I'm using jargon here, so I apologize. Don't get lost in the jargon, and I'll explain. But one cause of market failure in healthcare is what's known as information asymmetry, which is a form of market power. Specifically, physicians and other healthcare professionals, like professionals in other settings, not just in the healthcare industry, possess more information than their clients. And as a result, information on price, quality, effectiveness, and outcomes is difficult to obtain or understand because professions try to protect or prevent the release of this information. And in fact, overcoming that professional barrier or resistance often requires legal action or legislation to require the disclosure, because the profession has an incentive to keep this information from being publicly available. It also means that the classic example I learned in policy school of information asymmetry is when it comes, again, getting back to cars, when you go in for service on your automobile or something's wrong, you know that the check engine light's on, but you don't know why. And it could be a $50 repair or it could be a $5,000 repair. And the question is, now, how do I assess what the mechanic is telling me? Am I being taken advantage of? And unless I know a lot about cars, we're all subject to that kind of potential information asymmetry. Especially now, when I used to be able to, that unreliable car that I talked about in high school, I knew how to get in there and muck around with that engine and get it started. When I open up the hood of my car now, it's just a mystery to me. I close it and say, plug it into the computer and let the computer diagnose it. But I don't have a computer at home to diagnose that car. Another source of market failure in healthcare is physician agency. So physician agency refers to, in fact, the positive side of information asymmetry. It's physicians and health professionals, because they're professionals, will function on behalf of their patients. The problem is that it's difficult for any professional to serve as a perfect agent on behalf of their patients. Why? It's not because of bad intentions. It's primarily because it is difficult to fully understand all of the needs, preferences of individual patients. It's almost humanly impossible. So the best we can do is sort of approximate and do what we think is best and try to engage in effective communication. But I'm sure all of you are familiar with the studies that show that patient-physician interactions are almost like people speaking 2 different languages. What is said by the doctor and what is received by the patient can be very, very different. And there have been some really interesting both video analysis of those patient-physician interactions, as well as analysis of transcripts. And it is almost at times like people are speaking on two different levels. A third source of market failure is what I referred to a few minutes ago, which is the fact that there's extensive insurance for healthcare services. Now, what this does, and some of the pioneering work in health economics that was done back in the early 60s, and specifically an article that was written in 1960, I think it was 1963, talked about moral hazard. And moral hazard is, in a sense, it's a form of externality. Now, the term really came out of the insurance industry, not health insurance, but insurance. The idea of moral hazard is that if I have coverage for my business, that I might have an incentive, if things are going bad, to make sure that somehow that business mysteriously burns down. So having insurance creates an incentive to do something that might not be legal. And it creates a financial incentive to be rewarded for a bad outcome. In healthcare, the idea of moral hazard is less about your morality and more about the economics. When you're insured, the cost to you of the service is either zero or significantly lower than it would be if you were paying the full price. And basic economic theory tells you when you lower prices, people will buy more of that services, all things being equal. So in this context, the moral hazard is not a judgment of the character of individuals. It's more that when you lower the price by providing extensive insurance, people will use more, and they may use more than is really necessary, but they're responding to the price, the lower price, as opposed to the true value of the service. Now, there are mechanisms to counterbalance that, but it's been recognized for about 50 years that health insurance has this unintended effect and may lead to higher use of services beyond which we're actually getting the true benefit or value. The other, and this is really relevant to the rest of today's talk, is that uncertainty is rampant in healthcare settings. The fact, and it's a form of incomplete information. It means that a lot of treatments and services are risky, and the outcomes are uncertain or probabilistic. There are very few examples of healthcare treatments where we can say, I'm going to do this, and I guarantee that this will be the outcome. No question. There's always a chance, there is always a probability that there will be some other, perhaps adverse outcome. Might be extremely low. It might be 0.0001%. But the fact is that we, unlike, say, chemical reactions, where we write equations that are exact and deterministic, or physical laws on sort of the macro level, not the subatomic level. There are certain physical properties where we can write definitive equations and say with certainty this will be the outcome. In healthcare, we're talking about probabilities, and as a result, that sort of sets the stage for a lot of the rest of what I'm going to be talking about today. As a result, medicine is both an art and a science, and what it means is that there's a scientific basis for medicine, but as a number of health services researchers have demonstrated over the last 40 years, there's also variation in the practice of medicine that has nothing to do with science. It has to do with basically what has evolved because of local tradition or the way I was trained during my residency, for example. So those variations arise without any scientific basis, and they exist side by side with practices that have a good scientific basis. Yes, you had a question.
Just comment about the moral hazard.
Yeah.
The thing that's slightly different in medicine is in healthcare, you also have the physician there. I mean, physicians are also more likely to order or task on a patient if they know the patient is insured.
Correct.
So the thing is, patients are more likely to seek more things to be done if they're insured, but then providers also more likely to do. So you kind of compounds on that.
Exactly. And as I mentioned, there are mechanisms to, in a sense, deal with that aspect of insurance, and that's why we have managed care and capitated payments, etc. So it puts a break or a overall budget constraint, let's say either on an individual or on a group practice, to say, we're not going to tell you that you can't offer this care, but what we're telling you is that we're going to pay you this amount of money on a monthly basis, and you figure out what the right mix of services and when to say stop. But it's not an unlimited situation. And that's one way of controlling the moral hazard that exists in healthcare. Anyway, getting back to the uncertainty, this is why we have practice pattern variations. And John Wenberg is really a pioneer in this area and wrote a definitive article years ago about small area variations. And if I remember correctly, he was talking about differences between New Haven and Boston, and that basically within a relatively small geographic distance between two major urban areas, he observed and documented significant variations in the practice of medicine that were unexplained by population or underlying health differences in the population. And that if there was a Nobel Prize in health services research, I think that work would have qualified. And then the last one is the difficulty in assigning property rights, and this is the public goods. And this really, in a sense, applies to public health and prevention. A lot of the things that we do in public health, a lot of the innovations, are things that are difficult to trademark. They're basically, it's difficult to own them. And if you can't own them, then you can't monetize them or capitalize, literally capitalize on them and market them. And as a result, the market fails here because those innovations may be valuable, they may have a big impact, but there's no profit motive. And as a result, capital seeks opportunities for greater returns on investment. If there's no return on investment, there's not going to be any investment, certainly by private markets in this area. So anyway, I said that I didn't want to get too lost in sort of the economic jargon. What I really want to do is set the stage to say that what we're really trying to do in healthcare technology assessment is to provide information about the effectiveness and value of healthcare technologies, broadly defined, going back to my first slide, the broad definition of healthcare technology. And usually after these things have been introduced into the market. And I'll come back to why that's important, why the after is important. In other words, technology assessment is an alternative method for achieving what other markets do. They achieve economic efficiency through competition. Because competition doesn't, and specifically competition based on price and value, which is a combination of price and quality, because competition doesn't seem to be working in healthcare, we don't necessarily achieve economic efficiency. So the reason I'm teaching this class today is that we've developed these techniques to try and figure out how to become more economically efficient. The reason this isn't being done in the business school or even in engineering is that in a lot of other markets, the competition is going to force innovation. Because if you don't innovate, what happens? Your business dies. you literally lose your business. You can't stay in business if you're making the brick, going back to the brick phone. The brick phone is a funny thing that we see in a television commercial now. Guy walking, the guy who developed it is walking down the street, talking into the brick phone. I think it's hilarious. And that's only, 20 years ago. If the cell phone industry was like healthcare, the brick phone would not be a funny commercial. It would still be a viable option, and people would look at the two and say, I don't know which one's better. This one might be better, and it's certainly closer to where I live. So I'm going to use the brick phone today as my healthcare provider because I can't tell the difference. I can't see any difference between the two. This one went to good school. And I looked on the web and it has they have a 3-star rating. Maybe it's okay. So who are the audiences for technology assessment? Well, I think there are a lot of different audiences, and I've just listed 3 of the key ones here. I think that healthcare professionals are interested. Healthcare professionals, I think, want to provide the most effective treatment for their patients and want to be cutting edge. So this kind of work is of value to the profession. It's of value to consumers, although I don't want to overstate the value because I'm not sure that we could ever, I'm not a believer that we could make the healthcare market function exactly like the other markets that I've been contrasting. So we could provide consumers with all of the information needed to make informed choices, and I'm still not convinced that that would mean that we would drive innovation the same way. But I do think it's worth us continuing to make information more readily available to consumers. But I think this kind of information also has tremendous value to purchasers, which include governments, federal and state governments, as purchasers of healthcare services, and providers of healthcare through the Medicare and Medicaid programs. But I think insurers in particular do find this information very valuable. Let me just mention, so if there's a demand for this information and the market's not producing it through competition, we're doing it by studying things after they're introduced into the market. What's the process for doing this kind of technology assessment? Do we have, for example, a national body that's doing this work? Do we have a government agency? And how do technologies get identified for evaluation? Well, first of all, it's usually after diffusion into the market. Almost all the studies that you're going to read or ever be involved in doing cost effectiveness type work or economic evaluation is for something that's being used. It's not in the product development phase. So it would be, again, to use the cell phone analogy, it'd be like, well, let's make the brick phone and we'll make the iPhone. We'll put them both on the market and then figure out what people prefer. That's not really the way innovation's occurring in that market, or the market for these. Even this is outdated even now. I tell my students all the time that these laptops have more computing power than the mainframe computer that I did my dissertation on 30 years ago. That IBM mainframe that had a bunch of reel-to-reel tapes, and I would take a card deck to the computer lab to run my program, my regression program. The card deck was this long because the program was up here, and then this was all the data punched into cards. So these things are more powerful in the innovation and a lot less expensive than that IBM mainframe from 1978 or 79. But what we're doing in healthcare is we're developing these innovations and releasing them into the market, and then after they're being used, we say, well, which one's really more cost effective? How do we decide now that they're being used? Which one's really, in a sense, a better value? Well, as a result, what you see is a focus on things that have a high impact. So there's no systematic technology assessment that goes on. But if you look at the literature, the kinds of studies that get published on this, there are things that are high volume, things that have a high cost, either a high unit cost or account for a lot of expenditures. And then there are things that potentially have important impacts on health outcomes, things that have a big impact, particularly on mortality. So that tends to be what gets studied. But the fact is, it's usually determined by independent researchers, or in some cases by the manufacturers of specific products or devices. So the pharmaceutical industry, the device industry, does this work internally. But other than the FDA in the United States, there is no systematic public process in the U.S. to investigate new technologies. And I should have this in bold and underlined. There's no systematic process in the United States for technology assessment. In fact, Congress in 1995 eliminated the Office of Technology Assessment, which, by the way, had a very narrow responsibility for doing this kind of work, but nevertheless did this work. Now, the Affordable Care Act has a couple provisions that increase technology assessment, but it doesn't create a specific agency to do this on a regular basis. There are two provisions in the law specifically. One is what's known as IPAB, the Independent Payment Advisory Board. And although the primary purpose of this board is not technology assessment per se, its charge is to identify ways of keeping Medicare spending in line with the growth in our gross domestic product. First of all, this board has still not been appointed. So the law was signed 5 years ago next week, and this board has still not been appointed. Now, one of the reasons is because the trigger for establishing this board hasn't been met yet. Medicare spending has to go up at a certain rate before this board has any work to do. And Medicare spending and national health care spending has been relatively flat the last 5 years. So the trigger to cause the creation of this board hasn't been met yet, but it will be at some point. But this is one of the most controversial parts of the law, and that's saying a lot because basically everything in the law is controversial. But this, especially conservatives, have targeted this as something that needs to be eliminated. But the other piece of the Affordable Care Act that creates some focus on technology assessment, again, not as a primary, but more as a subsidiary aspect of this organization, is the Patient-Centered Outcomes Research Institute, or PCORI. And Dr. Washington was head of PCORI. And this organization, which is very well funded, is charged with improving outcomes and identifying and incorporating patient preferences into the healthcare delivery process. So improving outcomes while also incorporating patient preferences into the delivery of healthcare. And as a result, that is a form of technology assessment, but it's not really cost effectiveness or the other techniques that we're going to be talking about today. It's sort of one piece. It's the effectiveness and what works better, particularly when you involve patient and engage patients in the process. So what are some of the tools of technology assessment? I've been alluding to them. There are a couple different things. There's decision analysis, and I've already referred to the fact that uncertainty is rampant in healthcare delivery. As a result, this makes decision analysis a really valuable tool, because anything that has a probabilistic outcome is a perfect subject for applying decision analysis. And I should say that decision analysis is part of all of the three techniques listed in the last bullet there. So it's not, although I presented it as something separate, it is an integral part of all of those other three techniques that I'm going to be spending a lot of time talking about in the remainder of today. There's risk analysis, which is done, and risk analysis is done largely by organizations like the EPA. So what's the environmental exposure and what's the risk of disease or adverse health outcomes related to exposure to, say, different chemicals in the environment or pollutants in the environment. Health impact assessment is a technique that's evolved over the last decade or so. I was involved about a decade ago with Jonathan Fielding here at UCLA, working on sort of refining health impact assessment in the United States. It's used widely in Europe. There are different versions of this, so I wouldn't describe health impact assessment in all its applications as a tool of economic evaluation, because in Europe it's used largely for community involvement and community participation. It's less methodological and quantitative and more about process and making sure that communities are engaged in public programs and projects that may have an impact on their neighborhoods. But in the U.S., we were advocating health impact assessment as a method for identifying and explicitly attempting to quantify the health consequences of programs that might not be intended to affect health, but might nevertheless have important health consequences. And so, for example, one example of a health impact assessment that we did years ago was looking at the health consequences of expanding after-school care to all California kids. Now, the purpose of that bill was not to improve their health care. That was not the primary purpose. But the fact is that after-school care actually has a protective and positive health benefit on kids because, without oversimplifying, keeps them out of trouble between 3 and 6. And as a result, they're less likely to be injured and or killed. So it had actually very positive health benefits, and the purpose of health impact assessment is to say, if you overlook those secondary but nevertheless very important health consequences, you might be undervaluing the benefit of a simple thing like after-school care. Well, then finally, and this is what we're going to spend the next 2 hours talking about in more detail, are the tools of economic evaluation, all of which use decision analysis, by the way. And you'll see that as I go through. It'll be obvious from the slides. But the 3 techniques that are commonly used are cost effectiveness, cost benefit, and cost utility. And I'm going to define each of them and talk about how they're related in just a minute, I think, and then we'll take a break. The other point that I want to emphasize here, again, because these methods are sort of founded in economic theory, is that these 3 techniques are really, they use the same mathematical and mathematical sort of approaches as the tools that are employed by private companies when they decide how to maximize return on investment. So in a sense, what these techniques are doing are measuring return on investment from a social perspective rather than the perspective of an individual company. And that's the major difference. It's not that the technique is different, it's that your perspective is different. So if I'm let's just say a hospital, if I'm a hospital, I could calculate a return on investment of something that discharged my patients more quickly. Try to maximize my revenue from Medicare by getting people out the door faster because Medicare is paying me a fixed payment. From a societal perspective, that might not have a high return on investment because I might be discharging people too soon and just pushing them out the door so that the cost is borne by the family or by someone else, not the hospital. So from the hospital's perspective, it could produce a much higher rate of return. From a social perspective, it could be suboptimal. And that's why these techniques always tend to look at things from a societal perspective. But the underlying math, and I'll show you a little bit of the math, I'm not going to go into tremendous detail. It's the same exact equations that are taught in the business school. And it's based on discounted cash flows and discounted health benefits over a period of time. So let me just talk briefly about what these three techniques are and how they're related and different, and then I think we'll be ready for the first break. CBA, CEA, CUA. So cost-benefit analysis, I'll start with that, assumes that all costs and benefits can be measured in economic terms, i.e. dollars. Now, when we're talking about cost and measuring cost in dollars, that I think should be intuitively obvious to everybody in the room. Of course, if you're measuring costs, you can assign a dollar value. That's not always. Sometimes economic costs are different. It's a little bit more challenging than just measuring the dollar flows, and I'll talk about that in a few minutes. But it's the economic benefits. That's where in healthcare it may be more challenging to identify what the dollar value is of the benefits of healthcare interventions. But that's cost-benefit analysis, and the value of cost-benefit as a tool is you could make comparisons across different sectors of the economy. For example, I could do a cost-benefit analysis that says if I'm local government and I have $1 million to spend this year, would it be more effective to spend it expanding clinical services in my community? Or would it be more effective to spend it improving classroom education K through 12? And I could do that comparison. What do I get? What's the cost and benefit, or what's the benefit for $1 million spent over here versus $1 million over here? And I could put that on basically a common denominator. So that's the value of CBA. Cost effectiveness measures benefits in units of health outcome. So it still measures cost, obviously, in dollar terms, but the benefits are measured as typically things like years of life saved. And cost utility analysis, which is a special subset of cost effectiveness, measures benefits in outcomes that account for the quality of life. For example, and more specifically, using quality adjusted life years, which are known as QALYs. So cost utility analysis is a special form of cost effectiveness where we want to measure the quality of life. Just quickly, the major limitation of using cost benefit in the health sector is this thorny issue of how do we value human life. And it's not that we can't do it. There are agencies, government ministries of health around the world that assign dollar value to life all the time. Courts of law throughout the United States in deciding cases of injury, personal injury, premature death, put a dollar value on life every day. Juries do it, courts do it. So it's not that we can't do it, but it leads us down a path that might not be completely desirable for social purposes. The two techniques that we can use are the human capital approach, which is basically you are what you produce in a market-oriented economy. Now that ignores non-market activities and quality of life. But what this means, and I think it should be obvious to everybody in the room, I don't have a slide to illustrate it, but everybody's familiar with sort of curve that goes like this. Not quite a bell-shaped curve, but almost a bell-shaped curve. Well, that's the human capital approach. If you put value on the y-axis and age on the x-axis, our value measured by human capital approach is very low early in life because we're dependent. And then we mature and leave the nest and become productive members of society. And somewhere in our 40s or 50s or maybe even 60s, our productivity peaks. And then it's downhill from there. And that, in a nutshell, is the problem with the human value, the human capital approach to valuing life. It means that we're going to overvalue people who are quote-unquote productive members of society and undervalue those at the extremes of the age distribution. There's also, in economics, what's known as willingness to pay. And this is even trickier because it's difficult to measure. You can obtain it through what's known as revealed preferences or surveys. Revealed preference simply means what people do as opposed to what they say they're going to do. So, for example, one of the reasons we could say that real estate values are higher closer to the ocean in Los Angeles than inland is because people have revealed their preferences for the desirability of living close to the coast. And that's, kind of makes sense. They've revealed their preference, they'll put a higher value and pay more to live close. And there are actually health benefits to that. We've demonstrated that there are positive health consequences in Los Angeles, still the smoggiest city in the country, to living closer to the ocean than living inland because of the variations in air quality. So economists like willingness to pay because it maximizes social welfare, but the problem that many of us have is that it ignores the distribution of benefits, and it doesn't account for differences in income distribution or ability to pay. So, we'd all like to live in a healthier setting, but unfortunately, not everybody's has the same ability to pay, and as a result, it creates undesirable social consequences. So, I guess before I move on, the bottom line is that this is the primary reason why cost-benefit analysis is not done very often in assessing healthcare technology. It's difficult to solve these problems, and it means that we're more likely to find value in healthcare interventions that improve the health of workers and excludes the health benefits of either the young or the old, or people who are not actively engaged in the market economy. And willingness to pay simply would focus on people who have the ability to pay. So we would tend to undervalue any benefit to low-income populations. So cost-effectiveness analysis has become the technique that we use. And I promise we're getting to the break. The outcomes I've already mentioned, measured as units of health outcome, usually years of life saved. Although it's possible and certainly, I'd say common for studies to still focus on intermediate outputs because we often don't have a long enough time frame to observe the long-term health consequences and benefits. So we tend to focus on things like, I'm involved in a proposal right now that would look at a reduction in the rate of something. Knowing that long-term that's going to lead to increased life expectancy, but we're not going to be able to do the study for 40 years to actually observe that. We'd have to model that. And here's the key difference between cost effectiveness and cost. The outcomes are valued equally across individuals. In other words, a year of life saved counts equally regardless of whose life is saved. So workers don't count more than non-workers. Workers don't count more than the old or young. Everyone's counted equally. The other thing is that the outcomes are valued equally across conditions. So it doesn't matter where those years of life are saved. What the sort of the health conditions are. A year of life saved is a year of life saved is a year of life saved. It all is counted equally. The final point here is that indirect costs, such as things like days of lost work, are often excluded or averaged across populations to avoid problems associated with cost benefit. So in other words, there might be some health conditions where you say, well, look, the disability is important, we should measure it, but that's going to affect people in the workforce. It may not affect children. It may not affect seniors who are retired. It may not affect younger people who are not in the workforce. But those can be averaged across rather than focusing just specifically on the workforce. Cost utility analysis. So what's the difference between this and cost effectiveness? I said it's a sort of a subset or special case of cost effectiveness. It's intended to address one major limitation that analysts and practitioners identified 30 or 40 years ago with cost effectiveness. And that is that all the years of life count equally. So from a societal perspective, that was desirable because it doesn't doesn't discriminate, basically. But it ignores the fact that some years of life saved are with greater disability and limitation than others. So this isn't introducing or reintroducing discrimination or social inequity, but it's acknowledging that quality of life may have functional limitations and therefore tries to capture that. So it still assumes that a healthy year of life has the same value for everybody. And then the question is, where do you get the utilities? And most of the utilities that are out there in the literature and developed by different groups around the globe have been attained by doing surveys. And generally, the surveys are done on a broad representation of the population, not just people with the specific health conditions. So, final point that I want to make here is that cost utility and cost effectiveness analysis are often used interchangeably. Conceptually, they're not the same, but the fact is that I say here most, but it's really that all cost effective. No, I'm sorry. I've got that actually backwards. I'm sorry. I apologize. All cost utility analyses are there's basically a special case of cost effectiveness. That's a typo. I should have caught that. So we are at the break. So let me stop here and ask if there are any questions with what I've covered so far, including at Drew. There's nobody at Harvard. Any questions?
Yeah.
Hello. Yes, I have a question.
Yeah.
How do you really rectify, conflicts between looking at things from a societal and organizational perspective in the United States? Really, because when it comes down to any question of the term of costs in the United States, you have to look at it from in other countries, it means one thing, and you can really analyze things. But in the United States, what is the cost to, say, the government that's a gain from a hospital perspective. It's always going to be a conflict. So whenever you have a cost-effective analysis, one side might look at it as a positive, thing that we've saved this amount of money. But if you're looking at it as a hospital or any other payer, that's detrimental. That could close their business. And you're always going to have that conflict in the United States. So how do you really rectify and have a study that really says, this intervention is really effective, we should definitely move forward with this, when there's always going to be other sides saying, your data, no, that wasn't a positive finding of your study, that's very dangerous, we can't do that.
Well, I'm trying to think of examples where something would be cost effective but would be detrimental to the provider, but beneficial to, say, the payer. So I'd have to think a little bit. I'm not saying there isn't an example. I just haven't it might take me a little while to think about that. But the immediate answer to your question is that although the standard for doing and publishing studies in cost effectiveness and cost utility is to use a societal perspective, it doesn't mean that you can ignore differential consequences to various stakeholders. In fact, if you believe that you're doing a study that has a negative effect on the providers of care, but it's positive from a societal perspective, then I'd say I think you have an obligation to report those impacts, and you can disentangle them. The point that I want to emphasize is that it's not generally accepted to do things only from an organizational perspective, because the fact is that we assume that organizations are always going to do what's in their best interest, and sometimes what's in their best interest has negative social consequences or negative patient consequences, but it saves money for the organization and it allows them to increase their bottom line. So what we're trying to avoid in doing cost effectiveness studies is publishing studies that say it's a good thing for hospitals to send patients home 2 days after surgery, ignoring the fact that that increases mortality by 10%. And that's basically what we're trying to avoid. Trying to avoid legitimizing return on investment calculations from an organizational perspective that ignore negative social consequences or negative consequences for others. And I think that that's the primary reason for doing things from a societal perspective. But you do raise an interesting question, and I think it can be handled by looking at the consequences to all the major actors. So in my example, yes, it's more profitable for a hospital to send the patient home earlier, but when we look at the negative consequences on balance, we decide that this is not good policy. And let's say if from the Medicare program's perspective, because it's literally killing beneficiaries. And we don't want that. So I think that's the best way to handle it. To look at things from each major stakeholder's perspective, and then from the broad overall aggregate societal perspective. Does that answer your question?
Wasn't that one of the reasons why back in 1983 they came up with DRG, that diagnostic related groups, where when individuals went into the hospital, depending on whatever the ailment is, you had one set price, for the different ailments. I mean, that wasn't maybe too good for the patient, because no matter how long they stayed in the hospital only got a certain amount.
That's correct, and that's the reason I'm using that example, and you correctly sort of identified the underlying argument that I'm making, is because that's what I began my professional career doing, looking at the impact of DRGs. And the major concern that Congress had was they knew that changing this system was going to put hospitals at financial risk, but they were simultaneously concerned that that risk might be shifted onto patients by discharging them too soon. And that actually, for the first few years of the program, that was the focus of several major national studies to determine whether or not the financial incentives to discharge patients sooner were having negative health consequences. The conclusion of those major studies, including one done by RAND, was that although patients were not as fully recovered as they were prior to the DRGs, they were not suffering long-term, an increase in long-term disability or mortality. They were just not fully recovered, and they were spending more time at home recovering, whereas before DRGs, they would have spent that time in the bed. And I can attest, as somebody who's been hospitalized twice in my life for surgery, both times I spent one night in the hospital, and it was time to get up because we have really sick people now. that we need to put. And I was, led to the door as quickly as possible. And by no means was I fully recovered. But I was good. I was well enough to go home. And hospitals are dangerous places. The longer you spend, the more opportunity you have to get infection.
Jerry, you indicated that health plans have to offer U.S. Preventive Services Task Force strength and recommendation A and B as benefits. What is there a penalty if they regularly if the plan regularly allows for strength and recommendation D?
No, I don't think there's a penalty. I think it's a positive requirement as opposed to a penalty. So the ACA says that insurers and Medicare must cover at no cost to the individual all preventive services graded as A or B. And because that list may change over time, obviously, over time, there'll be some changes either in the grades or in, something new that comes along. But if an insurer wants to pay for something that has a poorer grade, I don't think there's not a penalty per se. There's just the implication is that you're paying for something that's not where the evidence is very equivocal or non-existent. I don't know what the D grade means. I'd have to look it up, but I think the idea of the D grade is, again, common sense. If there's the evidence is graded as D, there's no real good evidence that this makes a difference. So
unfortunately, it's not common sense because the whole Choosing Wisely campaign is directed against physicians who regularly, do things that aren't really, where there is no evidence for, and so every specialty group has Choosing Wisely recommendations, and those are all your U.S. Preventive Services Task Force strength and recommendation D items.
So you're saying we continue to pay for services and recommend services where there's poor evidence. Is that correct? Am I correct?
Yeah.
Yeah. That's why I'm teaching this class. So the practice of medicine is scientifically based. It is a $2.6 trillion industry, and we're still trying to figure out what really works and what doesn't. Is this phone better than this brick phone? The market decided 20 years ago. That's why the brick phone is a funny example in a TV commercial. But in healthcare, we haven't figured this out yet. And that's literally why I'm teaching this course. Because if healthcare worked this way, it wouldn't be a professor teaching how we figure out what works and doesn't work. This would be being done in the hospital. There'd be a team in the hospital figuring out, we can no longer do surgery this way because it's not the best way to do it. And we're going to stop doing it. And the insurance companies would say, we're no longer paying for this because there's no scientific evidence that this matters. We're paying for no outcome. There's no value. But this market doesn't work like other markets. So we're still paying for the brick phones. So let's take a break. And make it about 7 minutes. Okay, I've got 10:35 on my watch, so 7 minutes we'll resume.
Scholarship data.
For anything preventative, since you can't really monetize preventative things. So from the hospital's perspective, the most they make most money on surgeries that affect small people that are extremely costly those days. It seems like an excellent, great if anything you can do that can cut out those really expensive things like we last time with the amputations for those are really preventing that none of those should happen. Yeah. So, but there's really no incentive to you just having a study that says, oh, look how much money we can save. That's not. There's no. People aren't going to really jump on board because from even a hospital side or peers, they're like, well, that's costs our most expensive. That's our biggest profit margin there. And so if you cut those things out, our hospital's doing even worse. So with preventative things, it's not as easy to just have show the societal perspective because even though it looks great from a perspective, everybody else isn't willing to go with it because there's some negative on their side.
Yeah, and the problem in our country, as evidenced by the epidemic of measles right now, I mean, every parent should have had their children immunized. But unfortunately, in our country, autonomy trumps beneficence and non-maleficence, right? When you really get down to it.
You brought up about regarding if it's graded as a C or a D, does that have in terms of based on the outcome if it's still being offered or?
Well, see, U.S. Preventive Services Task Force, they grade by whether there's evidence. There's very good evidence by randomized, double-blind, all the requisites of a really good project, and multiple projects that show good evidence. And B is some studies that, pretty much support, and then all the experts all agree, yeah, we should be doing it. D is actually, the recommendation is against doing it. That the evidence shows that it's dangerous or offers no benefit whatsoever. And still there are a lot of hospitals around and a lot of insurance companies that are paying for a lot of stuff that really shouldn't be done. So.
Based off if it's not evidence supported that there's an effect on the deed, but there might be a return on that investment by offering that service.
Yeah, I mean that's probably the reason that this course is important. That you kind of have to weigh all the pros and cons and who benefits, who doesn't benefit. And here in this country, a capitalist society, the insurance companies are the major beneficiaries of any.
Yeah.
Because they're the ones who rake in all the money.
Yeah.
As opposed to other countries where it's the government that decides.
Yeah, that's
what's
everywhere.
Good for everyone.
Yeah, and everywhere else it's because since it is the government that equates to public good.
Yeah.
So the public is saving money. But here, it's well, one thing if it affects Medicaid, that's the major payer, but if it's affecting the insurers, that still can be good for the public, but it's bad for the insurers, and they have much more sway than it.
I thought we were supposed to have a minute recess in honor of Tony Yancey. You guys know Anthony? She was the director of it's originally UCLA Center to Eliminate Disparity. And the Kaiser Brigade UCLA Fairmont chunk change. They changed the UCLA KP Center for Health Equity. Eliminate health disparities, get health equity. those of you who know, I retired from Times Permanente after 35 years. And I've been here since that time because Dave Carlisle knew that I was retired from Permanentes. Because during all that time, I've been a volunteer at Venice Family Clinic, Savant Community Clinic. I helped start Asian healthcare venture. The
All right,
mission
so
of
I think it's time to resume. I'm running a little behind. I just realized that break, needed to be about 15 minutes earlier, so I'm going to need to speed up a little bit. And I want to say, the discussion we're having right at the end is very interesting to me personally, and but what I do want to say that sort of as preamble to the remainder of my talk today, which is now about an hour and a half. That the techniques that we're talking about and the issue that was on the table right before we broke is that, yes, we are paying for a lot of things that might have questionable value, and this is a big social issue. The techniques that I'm talking about today are effective ways of measuring the value of healthcare services. But the other thing I wanted to say is not only do we not have a government agency that has primary responsibility for doing this, more specifically, Congress's attitude towards the work that I'm talking about has been openly hostile in recent years. And specifically, for example, PCORI is not allowed to look at cost-effectiveness issues. And this is a real challenge because Congress is basically saying, we don't want government agencies rationing health care. And the techniques that we're talking about today could lead to not paying for some services and paying for others. And there's a very strong coalition within the Republican Party that does not want any of this to be done at the government level. They want the market to sort this out. And I think I've made persuasive arguments today why the market will never sort this out satisfactorily. But that's where that's the bigger social consequence, or I should say, context of what I'm talking about today. Yes?
But, one of the things you mentioned, your example with the brick phone and the smartphone, the thing is, and you also mentioned that this is not being taught in the business school, but increased efficiency, economic, financial efficiency in every other sector leads to greater profitability for firms.
That's
so
correct.
There is a natural incentive to do this.
Right. It's competition. It's competition for market share and profits.
Right. For example, all of our employers, your employer, our employer, UCLA, if your research ends up leading to the fact that some of the payments are going to be slashed, or some of the services are not being provided, it is going to lose profit. So there's, the very institutions, all the providers, from hospitals, institutions to different healthcare organizations, a lot of them are all going to increase efficiency means decreased profitability for a while.
Right. So what you've identified is the problem with how we pay for healthcare services, because when we pay for individual services, we basically, innovation penalizes because it means you'll no longer be paid. Imagine the car manufacturer who says, I'm no longer going to use this part because I can do something more efficiently. If I were charging for every part that went into the car, then I'd be lowering my profits by no longer using that part. So I might have a financial incentive to use something simply because I'm being paid for it, as opposed to it's the best way to put the car together. And that's what we don't do in healthcare. We're still, despite all the advances we've made in bundling services, we still largely pay for units of care broken down into pretty small units. And as a result, every time you become more efficient and therefore prevent people from coming into your hospital, you're losing revenue. And that's not an economic incentive, that's an economic disincentive.
Right.
So that
right. And that's why, in a nutshell, you're going to have a lot of resistance from the political sphere as well as from all the stakeholders.
Yes.
Because you're going up against capitalism in increasing efficiency in healthcare, whereas you're going with opposed to increasing efficiency in all the other markets.
That's exactly right. It's just another example of why this market is not functioning properly. And the question is, do we continue to go down the road of trying to make it work properly, and like other markets, or do we recognize that maybe we'll never be able to overcome some of these obstacles, and maybe we need to take a different approach? So, but as interesting as that discussion is, I'm going to put a lid on it because I need to get through the methods, sort of the nitty-gritty of this. So, but I could literally speak for hours on this issue. So let me shift gears now and talk a little bit more specifically about cost-effectiveness analysis. And so about 20 years ago, a number of distinguished people working in the field of cost-effectiveness were appointed to a government panel. They produced a series of articles that were published in JAMA, as well as a book that's widely used. I used it in the class that I've taught over the years on cost effectiveness. And the panel was the panel on cost effectiveness in health and medicine. And what their charge was to try and standardize the field of cost effectiveness analysis. There was, by the mid-90s, lots of groups in the U.S. as well as worldwide were interested in doing cost effectiveness studies, saw the value of the tool, but the technique was being applied in a variety of different ways. What it meant was, because there was no standardization in the way the studies were done, it was difficult to compare the findings across studies. So there might be hundreds of studies on, let's say, the value of breast cancer screening, but the QALYs or the cost per year of life saved was not necessarily comparable across different studies because of the way that costs were measured or the way that discounting was performed, et cetera, et cetera, et cetera. So the goal of this panel was to create a set of recommendations for standardization about what goes into the study. And they came up with this framework, which is to clearly state the objectives and perspective of the study, to identify all the possible alternatives, to identify and measure costs and benefits. That would seem obvious, but how you do that is not. To discount future costs and benefits, and I'll come back to this. This is why I was saying that the technique is basically what's taught in return on investment or cash flow analysis. To do sensitivity analysis, to look at how sensitive your results are to changing your underlying assumptions. And then finally, to discuss assumptions and results that might be difficult to quantify. For example, ethical issues that might arise related to treatments or decisions not to treat. Objectives and perspective. I just want to go quickly through these. So we've already discussed this a little bit. You can do an economic analysis from a lot of different perspectives. You can look at providers, payers, the societal. The recommendations of the panel was that cost effectiveness should always be done from the broadest perspective, that is, from society's perspective. And simply stated, for the reasons that I already mentioned when we were talking in response to a question earlier, which is that if you don't look at the broadest perspective, you could draw conclusions about the favorable aspects of an intervention by simply focusing on an organizational perspective and ignoring the negative consequences that spill over to society or to individual patients. But the bottom line, I want to go back just quickly. The bottom line is that not every cost effectiveness study that's published is from a societal perspective, but the panel's recommendation is that if you clearly state what your perspective is, then the reader can decide whether they think the information is of value. And generally, I will say, having been involved in these studies, I've been involved in studies where we say we're looking at the provider perspective because A, we believe that there are no consequences that will spill over outside the provider, but we have to argue that. Secondly, we want to demonstrate that this makes sense from an economic perspective from the provider, that it's of value to them. So our primary goal was to say that the provider will see the value of this, and there's no negative consequence to ignoring the cost to others outside the organization. This, I hope, is obvious, but basically, what this is saying, this part of the recommendation of the panel, is that you can't sort of cherry pick the alternatives. So if there are 7 possible ways of treating a patient, if you're going to do a good cost effectiveness, you should really be looking at all of those, not looking at the 2 that in a sense are most favorable. It's really worth looking at the entire set of possible interventions. And in many cases, the alternative to whatever the intervention is, no intervention. In other words, usual care is often the comparator, and usual care may be watchful waiting. We don't have an effective treatment yet for this, so we haven't done anything. And now we have something that we can do. The most recent example I can think of that I was involved in was HPV vaccine. We didn't really have an effective. We waited until people got cervical cancer or cancer. So evaluating the cost effectiveness of the vaccine was compared to not having a vaccine at all and just waiting until the cancers developed. Identifying and measuring costs. I'm going to spend more time in about a half hour talking about this, but just generally right now, the costs include the direct actual expenditures for things like labor, supply, equipment, and obviously the cost of the intervention or the treatment. Then there's this issue of, well, what about things like indirect or overhead expenses? If you're talking about a hospital-based or any sort of organization, there's the direct cost of providing services, but then, there's the overhead associated with running the organization. And this is difficult. It depends on how good the data is that you have. In theory, if the overhead expenses aren't really being changed as a result of your intervention, then you could ignore them and just focus on the direct cost. The reality is that in a lot of organizations, they don't have enough detailed cost accounting data to separate the direct versus the overhead, so they end up getting averaged in together. This is more of a technical issue, but the fact is that in theory, we'd like to keep anything that's not changing or not directly affected by the intervention out of the cost, but it's often difficult to do. Discounting cost and benefits. These are the equations that I said are basically what's taught in the business school and in business schools around the country. But an important step in doing these studies is to discount cost and benefits to account for the effects of time. And the formulas are essentially the same. Costs are the sum of cost discounted over time periods by a factor that is equal to 1 plus I raised to the t power. Well, t is a time period, so think about it as a year usually. And I is a discount rate. Now, the discount rate here is not inflation. So we're not talking about inflation. The economic concept and the rationale for discounting is that future costs and future benefits are worth less than current benefits. And in sort of economic theory, when you think about cost or think about money, it's the time value of money. $1 in the future is not, 10 years from now, is not the same as $1 today. And it's not because of inflation. Even if we net out inflation, the fact is that I can use $1 today to invest in something that in 10 years will grow into more than $1. I can put that dollar to use, and I can make it productive, and I can earn a rate of return on it. independent of inflation. So a dollar in the future, if you're offering me, I'll give you $1 in 10 years, or I'll give you $1. You should always take the dollar today. And this is fundamental to any business strategy. But this is the part that's less intuitive. What the panel on cost effectiveness recommended is that benefits are also subject to the same effective time, that future benefits should be discounted the same way that economic resources, i.e. dollars, are discounted. And this was controversial at the time, and by the way, is in the field an ongoing source of debate. There are some people who argue that if you discount benefits, you're kind of ignoring future generations. Because even with a simple discount rate, the mathematics of this say that in 100 years, a discount rate of 3% a year means that a benefit that accrues 100 years from now is minimal in current value, or in the current time period. Discounting has the effect of basically diminishing the value of something over time until it becomes very small, the further out you go. So there are ongoing debates in the literature about whether benefits should be discounted. But here's the key. So two colleagues of mine, Shan Cretin and Emmett Keeler. Shan was former chair of my department when I came to UCLA 26 years ago. And Emmett is a researcher at RAND, who's done, among other things, worked on the RAND health insurance experiment. Shan and Emmett published a paper about 30 years ago that said, if you don't discount benefits at the same rate that you discount cost when you do these studies, you'll get what they call a paradox. And it's the Cretin-Keeler paradox. The paradox is that if you wait another year, because cost effectiveness is cost divided by benefits, if benefits never diminish over time, but costs do, you'll always have a more favorable cost to benefit or cost effectiveness ratio if you wait another year. Because next year it'll be cheaper, but the benefits will be the same. But then if you wait 1 year, wait for another year and it'll be even cheaper. And then wait for another year and it'll be even less expensive. So what they said is the paradox is that as a decision-making rule, you'll never implement the technology because it will be infinitely better to wait, i.e. never implement, because it's always going to cost less the more you wait. And they said that can only be resolved by discounting both cost and benefits at the same rate. And the recommended rate is 3%, net of inflation. And I'd be happy to talk to you separately if you still are confused about what is inflation and what's the discount rate. But the discount rate is, as I say, after you remove the effects of price inflation in the economy. Yeah.
How do they derive this? I mean, in kind of a broad stroke terms, how do they derive the 3%? I mean, how do they arrive at any type of percent for this? I mean, what is the algorithm they?
Well, it's not an algorithm. It's not really an algorithm. So here's the problem, or the challenge, and your question's a really good one, because for economic resources, I can look online at what current markets are, what the rate of return is in markets, and you can net out your assumptions about inflation and say the real rate of return if I invest $1 in the stock market for the last 80 years is roughly 7% a year. That's real value, and I've got historical data, and I know that, and that actually guides my decisions about where to put my retirement money. I mean, it's not a hypothetical question. It influences, how I invest my retirement money.
So this is basically.
But how do you do this for benefits. What's the right rate of return on benefits? And what the panel argued is that it should be based on a social rate of return, which is difficult to measure. But the idea was that it shouldn't be as high as capital markets, because the social rate of return, the higher your rate of return, the more you discount future costs and benefits. So they, in a sense, compromised. They said, on the one hand, people are saying you should never discount benefits, but we believe the Cretan-Keeler paradox. By the way, Emmett Keeler was one of the members of this panel, so he might have had some influence over their decision to accept the paper. It was a good piece of work independently. But what they argued was, well, you've got a discount because of this paradox, but if you discount at a too high a rate, like an economic market, then after 20 years, nothing matters. And you can do the math. You can plug in a 14% rate of a discount rate and look at what that does over 20 years. And basically, after 20 years, everything doesn't matter. Which is why investors would say, if I can get a 14% rate of return, I don't care about 20. I want that return now. There's a high cost to delay. I need to invest now and take advantage of that opportunity. So it's a little bit of, it's art. It's not something that we can easily look up.
So essentially you're saying the rate for the cost adjustment, that's based on like a kind of an 80-year aggregate looking at what the return on the dollar is.
No. What I'm saying is that this 3% figure is based on a hypothetical social rate of return, which is actually lower than the rate of return that capital markets would provide for investment.
So this was basically decided based on a panel of people.
This is expert judgment, is what you, or consensus.
Okay.
Consensus decision, that's right.
Okay.
With reasonable rationale, but I introduced the idea of the rate of return on capital markets because there's an example where you can go look it up. There's actual data, historical and current data. I can look on, what the markets are doing today. But there's no place where I can look up a social rate of return.
So this is like a level.
Because where's the market for trading health benefits today versus health benefits of my grandchildren? Where's that? What market? I mean, the Chicago Board of Trade's not doing that.
I didn't know whether modeling was used to come up with something. So this is a consensus.
It's a consensus, yeah. So cost effectiveness ratios, and I don't mean to oversimplify it, but in its most simple form, what we calculate are incremental cost effectiveness ratios. The ICERs are what they're called. And this is really the goal of cost effectiveness. We want to get an ICER. And an ICER is the change in cost versus the divided by the change in health outcomes. So if we're doing a comparison, and this is generally if there are more than two outcomes, we're doing pairwise comparisons. So the ICER would be, the cost of B minus the cost of A divided by the health outcomes of B minus the health outcomes of A in its most simple form. Now, I want to spend a couple minutes talking about the cost effectiveness sort of decision space. So if we do a simple, two-dimensional graph of outcomes on the x-axis and cost on the y-axis, cost effectiveness, what this does is it leads us into sort of four quadrants that have different implications for decision making. So starting with quadrant 1, where costs are higher and health outcomes are better. In this quadrant, the cost effectiveness ratio, and really when I say, what I really mean here is the ICER. The ICER is greater than 0 not if, in this quadrant, the ICER is greater than 0, and the health outcomes are positive. So the decision here, or the conclusion, is that you want to adopt technologies or treatments or interventions in this quadrant as long as the ICER is less than whatever you've determined to be your maximum. And I'll talk a little bit more about how we decide that. But the figure that's most commonly used is $50,000 per quality adjusted life year. And actually in Great Britain, where they have a commission that does cost effectiveness analysis for the National Health Service, they use 30,000 pounds as their maximum ratio. So anything that produces an ICER above 30,000 pounds per year of life saved is not going to be funded. But anything that's below that is considered cost effective. And I want to emphasize here that cost effective does not mean that it's saving money. It means you're getting better health outcomes, but you have to spend more to get those. And the question is, how much more should we spend? So moving counterclockwise around it, going over to quadrant 2, this is a case where you've got interventions, you've got essentially a negative ratio. It's because the denominator in the ratio, health outcomes, are getting worse. Well, this is, to put it bluntly, this would be the loser category. We're spending more and getting worse health outcomes. These are technologies or interventions or treatments that we want to flee from as quickly as possible. Run away from these like leaving a burning building. And you would hope that these don't get to market, but there are examples. I'm not sure that I can easily think of one, but this does happen. Now moving down to the third quadrant, this one is a little bit more difficult to understand. Mathematically it makes sense, but intuitively it's not as obvious what's going on here. Here the ratio is positive. But the ratio is positive because, remember from your math, a ratio of two negative numbers is a positive number. In this quadrant, costs are lower, but so are the health outcomes. So the ratio is positive. You're saving money, but you're also diminishing health outcomes. Now, this quadrant only really makes sense when you have conditions such as a budget constraint. So the most current or recent example I can think of was a few years ago when the state had a $20 billion hole in its annual budget. So the state of California suddenly found itself with significant shortfall in tax revenue and liabilities, and specifically liabilities for things like education and healthcare. So the state looked for ways of reducing spending in the Medicaid program to get through the budget crisis. And it came up with about, I think it was $4 or $5 billion in what they call temporary savings in Medicaid by eliminating 5 or 6 key benefits. And the way that they identified those benefits is to say we can get the maximum savings and have the lowest negative health consequences by eliminating these benefits. So, for example, they eliminated dental services. They eliminated podiatry care. And although I'm not saying that somebody in the state did a formal analysis, they effectively did what's going on in this third quadrant. They said, we're going to get, in aggregate, $5 billion of savings, but by eliminating dental care, we're not going to kill anybody. No one's going to die. People are going to have worse oral health, but we've got to get through this somehow. And this is the easiest thing to do and produces the biggest savings and has the least negative consequence. So this quadrant really only makes sense when you're forced to make tough decisions. You've got to give up something. Where do I get the most savings and have the least adverse outcome? That brings us to the final quadrant over on 4. Now we like this quadrant. This is where the ratio would be negative, and the convention in this, if your results end up in this quadrant, the convention is not to report the cost-effectiveness ratio whenever it's less than 0. But here's a case where you're saving money and improving health outcomes. Hallelujah. This is where we want everything to be if possible. This is truly the cost-saving intervention. We can improve health and save money at the same time. Now, Louise Russell, who has done a lot of work in this field, published a study a few years ago that showed that she did a systematic review of the literature and found over a certain time period that only about 20% of the studies identified technologies that fit into this quadrant. I actually thought that was high, but the fact is that most things don't save money and improve health. But they do exist. Most things fall into that quadrant number 1. You do get better health outcomes, but you have to pay more for them. Conducting sensitivity analysis, I'm just talking at a very superficial level here, but basically the idea is that I think we're all familiar with the idea that when we do statistical analysis, we usually come up with a confidence interval. Well, confidence intervals are a little bit more difficult to produce for these cost-effectiveness ratios. Mathematically, the reason for that is because things can go through the origin. And when things go through the origin, it means that the denominator is 0. And when the denominator is 0, things blow up. So there are other techniques that have evolved, but the point is that the panel's recommendation back in 96 was to do sensitivity analysis, and the field of sensitivity analysis and cost effectiveness has made a lot of advances in the last 10 or 15 years. There are different ways of doing that. But the point is that what they're saying is the gold standard is that you always need to show how sensitive your results are to changing the underlying assumptions. And then finally, incorporate non-economic factors. It's possible that there are other social, ethical, political, legal considerations that can't be measured in economic terms, but nevertheless may be extremely important in identifying the value of the intervention. So rather than ignore them because you can't measure them, discuss the potential impacts, recognizing that your cost-effectiveness ratio ignores or can't capture those important factors. So let me quickly go through an example of a cost-effectiveness analysis for breast cancer screening. And there's been a lot of work in this field. This study is actually, 20 years old, more than 20 years old now. But one of the reasons I use it is because it's a relatively easy, straightforward example of a cost effectiveness. It's easy to illustrate the principles. But because it was done prior to the panel that I just discussed, that panel's recommendations, this study is not completely consistent with those recommendations, although it's not a bad study. Obviously, the question of mass screening for breast cancer continues to be controversial, and there are literally thousands of studies that have been done on this topic. This is one of the earlier ones. They looked at the alternatives of self-examination mammography and a clinical breast exam. They identified, the various factors that can influence cost and benefits, including incidence of disease, length of the preclinical period, the effectiveness of the treatments, the cost of the initial screening, the sensitivity and specificity of the screening procedures, the periodicity of screening, which is also continues to be an ongoing issue, follow-up diagnostic procedure. I see everybody writing quickly. Now, the slides are available, right? Okay. I just want to make sure because, yeah, if you don't get everything, the slides are going to be available to you. Should have said that up front. Stage-specific treatment cost and the risk characteristics. So it's pretty comprehensive. So is it cost-effective? This is basically the results. You've got the screening results, and then determination of whether those screening results produce true positives, true negatives, and false positives and false negatives. So you've got a 0.15% incidence, sensitivity of 80%, and a specificity of 97%. Cost in '92, roughly $100 per mammography. So you've got 10,000 women screened at $100 per screening. $900 in diagnostic follow-up for those who screen positive. So that's the 312 who screen positive. All get $900 in diagnostic follow-up. And then $25,000 in terminal cost avoided for every life saved. So they didn't do years of life saved. Well, they did, but that was a terminal cost for every life that was saved. The benefits, detecting 12 cancers multiplied by 0.65 mortality rate times an effectiveness of 0.25 resulted in 1.95 lives saved, and that translated roughly into 46 total years of life saved, assuming an average of 23.8 years. So what does that look like? Well, total cost, the mammography screening, $1 million for the 10,000. Follow-up diagnostics, $280,800, and then savings related to lives saved, subtracted from the total cost. And the ICER in this case is $26,800 per year of life saved. And so by sort of most common standards, this would be considered to be a cost-effective intervention. And this, as I say, I like using this because it's a relatively simple, straightforward study that can easily be presented in a couple simple tables. Most cost-effectiveness analyses now are not quite this easy. But in principle, they're all break down to something this simple. Yeah?
I mean, these things, do they ever take into account sort of the cost of not screening? The thing is, for example, I mean, where is the cost of catching this late and having someone may go through a lot more inexpensive chemotherapy and more invasive therapies and things like that, catching something late, the alternative?
Yes. Yeah, in this case, they were comparing to, let's see, to self-examination. But what you're saying is, what about the cost associated with not being treated?
So the thing is, I mean, like, so somebody catching this in stage 1 versus, I mean, not doing this and catching this at stage 3, and you end up having to do a lot more invasive processes, and the person's having a low.
So what you've done is you've just identified one of the sort of the major limitations of this study, which is that it doesn't, although in a sense what it does is captures that in the terminal cost saved. So in other words, the way that they captured this is they saved 1.95 lives. So they avoided $48,000 in cost by saving those lives.
Right, but
so that's the savings.
In other interventions, I mean, you can also save.
But this is overly simplified, because there might be other costs that they didn't capture. As I said, I like using this example because it's simple, but because it's simple, it means that it's overly simplified. But that is the way that they attempted to capture what you're talking about, which is, and your question illustrates again how important it is. Whenever you're evaluating something, it's always relative to some other treatment.
Right.
It's not being judged sort of on its own merits. What's the cost effectiveness in isolation? It's how cost effective is A to B, where B might be, we don't do anything now because we don't know what to do.
Right. And then, the other consideration is the quality of adjusted life year is going to be different if you catch someone in an early stage versus if you catch someone at a later stage.
Oh, absolutely. And this doesn't do any of that. This treats every year of life saved equally.
Right.
And, this is a cost effectiveness analysis, not a cost utility analysis. But it's also a good example of, how by doing things too simplistically, immediately you sort of say, but wait a minute, what about? And the answer is, if you're doing these thoroughly and systematically, you need to model some of these more other consequences. So in this example, a couple of the limitations. Costs and benefits were not discounted according to the authors because the time frame of the analysis is 1 year. Well, I'd argue that's not really true. They at a minimum, they could have discounted the years of life saved because they assumed that there were 23 years, and that actually is easy to do. 23 years of life saved discounted at 3% a year is going to be like 18 years. So that's one thing they could have done. But, the goal here is not to be overly critical of this as much as to use it for discussion purposes. And then, of course, they also ignore false negatives in this. They showed 300 women who screened positive who were actually negative. You've got follow-up biopsy cost, but is that the only negative consequence?
That's the other thing is when you discussed before that when you're looking at many different alternatives, there are some alternatives that may have a lower false negative rate. The sensitivity you quoted there is 80%. Perhaps you do a breast ultrasound, breast MRI. These are higher cost things. They're going to have a higher sensitivity, and but if you took into effect the false negatives, could they become more cost effective?
No, exactly. And for all of these reasons and many more, that's the reason why there have literally been thousands of studies or hundreds of studies looking at the cost effectiveness of breast cancer screening. Because every author is saying, well, look, we're doing things a little bit more thoroughly, or looking at something that has been ignored in other studies. It's a very, very intensively studied area. Sensitivity analysis, you could imagine there being a range around all of these key assumptions. And although this is not in the original article, I put this up here as an illustration of the kind of table that the panel on cost effectiveness recommends being included in any study that you publish, which is listing, first of all the key assumptions that went into your model, and then what range you used, and what the justification is for that. So you'll often see this kind of table in cost-effectiveness studies where the authors lay out explicitly all the key assumptions, what the ranges were, and then what the source of that information is. Okay. So that brings me to the end of hour 2. Still 15 minutes behind, but
Just a comment about
yeah.
that table that you just had. I mean, that can serve as the basis, because the thing is, all the other numbers change with the incidence up top. I mean, so the thing is, I mean, do you think that was what's underlying the recommendation that perhaps we should be doing the screening in the higher risk, like, I mean, above 50 versus, I mean, from 42 to 50 range for age, because there are different age groups. There's different risks, different incidents.
Sure. Oh, absolutely. You mean the current recommendation?
Yeah, the current recommendations.
Yeah. But there's still controversy about that, right? Because there's the evidence, and then there's what people want to do. The evidence suggests screening starting at 50, right? But the guidelines are still at 40. And why is that? Well, that's a complex discussion, and I don't want to spend a lot of time on it because I still have a lot of material to cover. But my take on this specific issue is that despite what the cost effectiveness data show, no one wants to not screen and have a patient who develops breast cancer despite the evidence that it's not cost effective to do.
So is this
because every doctor will tell you, but when my patient gets it and I didn't do the screening, then I don't care what this study shows. Not this study, but these studies.
But they must have, like, I mean, tables like this for the couple of studies they used for the recommendation. I mean, they must have, like, the 40 to 50 range and the 50 and above range.
Yes, that's right, exactly.
For that.
And the point is that, it's not that there's zero risk. It's that it's not cost effective to do mass screening in that 40 to 50 age group. And it's because the risk factors are not clear. It's hard to target high risk women who are at high risk of breast cancer because, as my understanding, I'm not an expert in this area, by the way, so I'm getting a little outside my area of expertise, but I pay attention to what's going on. My understanding is that there really just is no way to predict who's at high risk. That the vast majority of breast cancers are with women who have no known risk factors.
So they just have to look at epidemiological data to come up with an incidence and go from there.
Yeah. So the data, the models tell you one thing, and even when faced with hard, scientific evidence, it's still difficult to accept as a decision rule. The decision not to screen regularly starting at age 40.
Right, so, because if you're the case, then it's 100%.
That's exactly
despite
right.
Whatever epidemiological data tells you.
Right. So, other questions? Questions from our remote audience?
Can you hear me?
Yes.
Okay. So aside from being a community faculty here at Charles Drew, I work for LA Care. So your PowerPoint has been really relevant to what I do. And one of the departments that LA Care has is the Family Resource Centers. The Family Resource Centers were created with the purpose of reducing healthcare costs by providing intervention and prevention services. So now LA Care wants us to start measuring how effective the Family Resource Centers have been at providing, at reducing healthcare costs But most importantly, are our free classes, because we offer free health education and free physical activity classes. They want to know how effective are these classes. So knowing my employer, I'm trying to figure out if really what they want to see is a cost-effective evaluation, or if it's more like a cost-benefit, or if it's both. So that's my question to you. They want to start this research, they want to get this research going, especially since they want to open 2 new family research centers, one in Palmdale, and they want a mobile unit. But how do we measure how effective these classes, these free exercising classes, or these health education classes have been on the community?
So, without getting into a lengthy discussion about your specific needs, it's going to be difficult for you to prove that you're saving lives or that you're extending longevity, because you're not going to observe. You don't have 50 years to do the study. So what you have to do is, what I talked about, is use an intermediate outcome. So you're going to have to identify some intermediate steps where your education program is leading to healthier behaviors that other studies have shown are likely to improve health outcomes in the long run. So how many people have, I'll just pick one. If you're trying to reduce smoking rates, how many people have stopped smoking? We know from a variety of studies that that's going to lead to longevity and improved health outcomes and lower costs, not just in the long term, but actually there's good evidence that when you stop smoking, you start saving money immediately. The figure that sticks in my head is somewhere around $1,000 a year in lower health spending almost immediately. So, but what those outcomes are, I'm not sure that I can identify them off the top of my head, but I think that's what you need to focus on. You need to focus on either reductions in health, negative health behaviors, or enrollment or improvement in positive health behaviors. And for every percent increase in the positive and percent decrease in the negative, you can say we're having a positive impact on the health of our members.
Thank you.
And I'd be happy to talk to you more offline, separately about how to go about doing that. But I think it's doable.
Okay, thank you.
Other questions? Okay, 5-minute break, and then we're going to race to the end. I'll give you an hour of material in 30 minutes, which means I'm going to speak twice as fast.
due to the Affordable Care Act?
There's controversy about whether it's the Affordable Care Act or not that's doing it, but
we don't want to give it credit.
Yeah.
Heaven forbid.
For 5 years now, healthcare spending has been growing at the slowest rate since we've been measuring over the last 60 years. So we're going through a historic period in terms of slow growth spending for healthcare. And nobody knows whether it's going to last, and nobody really knows what it's fully attributable to. Some of it might have been due to the recession. But we do know that insurance premiums in a lot of the markets, as a result of the ACA, were lower than they were before, and have grown more slowly than they were growing. But we only have a couple years, right? Markets opened last year, and now we've got year 2 data. See if that continues. But yeah, I think the indicators are pretty positive.
Hopefully, we'll have more years to accumulate data for it.
Yeah, part of that depends on the Supreme Court. And then the election in 2016.
And the two budgets that are being bandied about don't include it.
Yeah.
I mean, it's kind of interesting the thing you mentioned about England.
I'm sorry about that.
About England using this.
Oh yes, nice.
Yeah, because when I was a resident, I remember in our oncology ward, we had Brits fly over to get chemo because they did this type of stuff, and they said the NHS would not pay for their chemo anymore. So it was actually, more cost effective for them to fly. Well, they just had to fly over here in order to get the treatments because it was chemo was more expensive than that. It's £30,000 a year.
Yeah. And so the question is, did anybody do a study to find out whether the people who flew to the United States to get chemo actually had better outcomes than the people who didn't?
Had no incentive to do that.
I know right. And the point is, I'm sure that that somebody did better.
But the question here is, whoever is on that panel, if we ever get a panel, and I don't know who's on the NHS panel, I hope they're reading literature regular on a daily or a weekly basis at least, because you don't want outdated data. Things could have been. They could have been making decisions off of data 3 years ago that showed no benefit, but now somebody just finished a study that showed benefits.
Yeah.
And the government doesn't move that fast, so that's the problem here. Is that if you have a panel of people, and if they're not regularly making decisions based on.
Oh, of course, yeah. So I can't speak to the process because I know of NICE. I don't know how NICE does its business. I don't know the operational details, but I served on a similar government commission before I became a professor at UCLA 30 years ago. And our commission, believe me, first of all, the individual commissioners who made up the voting members of that panel weren't the ones who were reading all the literature. It was the staff and or all of the stakeholders who were lobbying for a particular issue under the Medicare program. So the information, the most current information, if you have a process that's set up properly, will get to the relevant commission, even if the commissioners aren't the ones reading all the literature. And that's what you would assume or hope is happening with NICE. That it's a lot of work to expect the panel members to be current with everything themselves, but if they have an appropriate process, then the information will get to them and be brought to their attention in a timely fashion. Then the question is, do they act in a timely fashion? Anyway, so we're in the home stretch here. I'm not going to speak twice as fast, but what I will do is you'll see there's some repetition in this part. And so as a result, I'll be able to go through some of the slides. And again, you have access to these, so don't worry if you miss something. I really, quite literally, especially on this part, this is for you to go back and look at if you need to, and you can refer back to these slides. So I think I'll be able to get through this in 20 minutes. I just want to remind you that, so I've been talking about cost-effectiveness ratios and ICERs, but there are really three types of cost-effectiveness ratios. ICERs are the ones that we're typically doing, but in theory, you could calculate an average cost-effectiveness ratio. I've actually seen these discussed, but this is not necessarily useful. This is usually an average compared to doing nothing. And anyway, you might see this sometimes in the literature, but these are not as meaningful. Really, ICERs are the ratios that you want to make sure you're reading about. These are relative to other programs or other interventions. And in some cases, doing nothing might be appropriate. It just depends on the intervention. The other thing is that with ICERs is that if there are multiple treatments, and the one example I can think that comes to mind that I've used in classes in the past is treatment for hypertension. You can do, there are multiple drugs available, and a staged approach is often the most cost effective. And if I recall correctly, starting with a diuretic is most cost effective, and then moving to, I don't remember, let's just say ACE inhibitor. I don't know if that's correct or not, but the point is that, initially one is most cost effective, but then you kind of run out of effectiveness, the next most cost effective. So when you have multiple options, you can use ICERs to create a cost effectiveness curve that represents a staged or sequenced approach. The other thing worth mentioning is a marginal cost effectiveness ratio. This is much more difficult to measure, but in theory would be useful for programs. And this would be measuring, this is more for programs than comparing alternative treatments. If I expanded my program by 10%, how much more benefit would I be able to produce? So this is kind of what's known as increasing the intensity of my treatment or program. If I were able to scale this up, basically, how much more cost effective would it be? And this is more useful in sort of organizational settings or program evaluation. So let me start with showing you what some of these decision models look like and trees look like. And please do me a favor, ignore all the math at the bottom. I just put that there for completeness sake. I'm not going to go through these equations, but they are there if you're so inclined. But what I want you to focus on is the tree itself. And I mentioned earlier in this morning's talk that decision analysis is a key tool that's part of cost effectiveness studies. And this is the visual proof of that. This is a kind of generic cost effectiveness analysis of a preventive treatment. And so you can think about people getting prevention. The first node on this decision tree is whether or not they get the preventive treatment, yes or no. In the no portion of the tree, you basically have two outcomes. You don't get prevention and you get the disease, or you avoid the disease. And both of those outcomes have a probability, P5 and P6, and both of them have cost and health outcomes associated with them. That's what the C and the H represent. In the top part of the tree, for people who do get preventive treatment, you're going to have the same two primary outcomes. People are going to avoid the disease or they're going to get it. But you also now have within each of those categories two other possibilities. There's the possibility that people have adverse effects related to the preventive treatment. And so, vaccination or the lack of vaccination has been in the news. Why? Because in this example, in my example, P1, the probability of having an adverse effect of vaccination while not getting the disease, i.e., let's say measles, is assumed by a portion of the population to be enormous. Or the other explanation is at the end of P1, where we're talking about the cost and the health consequences. The health consequences of being in this category are assumed to be devastating, i.e. autism, or something other horrible. So as a result, I'm not going to get vaccinated because the possibility is unacceptable. It's unacceptably high. Or even if it's rare, the consequence is so severe that I don't want my child to be exposed to that. And so the question is, what are the probabilities of having adverse versus no adverse, and then the cost and the health consequences of that. But the reason I structured this way and used this example is basically to illustrate any preventive treatment that you can think of more or less is going to fit into this general framework. Now, this is the oversimplified version. You can imagine each of these 6 final decision points or nodes here, and those are the red triangles. Those are called terminal nodes in the jargon. Each of those terminal nodes could potentially maybe be further subdivided. The adverse effects, for example, could be multiple adverse effects, some of which are less horrible than others. So you get the idea. You could further refine this almost infinitely, but in its most general form, this is what every preventive treatment breaks down to. And basically, the idea is that you hope that people avoiding the disease and avoiding adverse effects, in other words, in this example, P2 is much, much higher than people who don't get the prevention. So you're hoping to see a much higher probability of people avoiding the disease. And you're hoping to minimize P1 and P3. And ideally have zeros for them. This is what the ICER looks like mathematically. Again, I don't want to, my goal is not to overwhelm you with mathematics and formulas, but the idea is that basically it's a matter of multiplying the probability of being in each of these states times the average cost, which is C bar, or the average health consequence, H bar. And you can, basically represent the ICER in this I know it looks like a lot of math, but it's a really, relatively speaking, an easy calculation. So what's the general sort of representation of the cost effectiveness of a new diagnostic treatment? Well, again, it's kind of can be simplified to comparing the old versus the new test. Both tests have positive and negative results, and each of those results can be true positives or false positives, true negatives or false negatives. And what you'd want to see in this new diagnostic test, if it's really better, is you'd like to see P1 higher than P5, and you'd like to see P3 higher than P7. Basically, any new test that you're evaluating compared to an existing test can be represented in this kind of tree. And again, the ICER, can be represented as this formula. And then similarly, if we're talking about new treatments, new intervention, new versus old, people are going to either recover or not recover after treatment. And people who don't fully recover can survive and live with ongoing disability, or they can die. For people who have the intervention, they can recover with complications or have a full recovery. And that's true both with the old and the new. And so basically what you want to do is you hope that your new treatment has more people falling into the full recovery category than previously. And for people who don't fully recover, it's not clear that you're necessarily going to have better outcomes there, but you hope that P3 is higher than P7. So I hope that you see that there's sort of a consistency here, and you can represent these problems or these studies in kind of a generic way. So I went through that very quickly, but let me just stop here. We're not done. I still have a little bit more to talk about. But do you see the pattern and basically how we're setting up these problems? Now, one of your questions might be, well, how do I do this? I mean, those are nice graphs. How do I do it? My simple answer for you is there's great software available. I made those graphs with this software. The software is called Triage. It's a play on the, triaging patients. It's a clever name, but it's actually spelled Triage, which is also clever because these are trees that you're building. You're building decision trees. So Triage is pronounced Triage is actually Triage. And it's extremely useful software. If you get to a point where you're doing these studies and you actually have to do it, you can build these trees with point and click. I mean, you can make all those graphs in like two or 3 minutes, and then you can fill in the data, the probabilities, fill in the cost and the health outcomes, and you can do a simple analysis. Literally, if you have the data already, you can plug in the numbers, run it, and do things in 15 or 20 minutes.
And how expensive it is?
It's not cheap. I don't know how expensive it is at this point, but because they market largely to the pharmaceutical industry, they charge it's expensive. However, they have educational discounts, and they have a student discount. You can get a limited version that allows you to build a tree with up to 125 nodes for pretty inexpensive. I don't know exactly what the price is right now.
Well, a lot of universities in the industry have access to things like this already.
Yeah. So I just want to spend the last 10 or 15 minutes wrapping up talking about some of the challenges. I went through very superficially the steps in doing a cost effectiveness. I've showed you what these trees look like, but really, the real hard work is not building the trees. That's kind of a conceptualization of the problem. And in fact, because there's been so much work in cost effectiveness the last 30 years, and especially in the last 15 or 20, you can actually find trees in the literature and say, look, I'm working on this problem. Some other team of researchers has already defined a tree that's appropriate to my issue, so I don't have to even think through the tree. I can just literally, recreate theirs. But I want to do a study on a different population, looking at different issues or whatever. I think the prevalences or the change in the incidence will be, different in my data. So even though the generic tree I can borrow, I've got to actually go out and collect my own data. So how do you do that? Well, obviously, in a cost effectiveness, the way that you collect cost data is crucial. And just to give you an idea, where does the information come from? Well, you're interested, obviously, because we're talking about health interventions, typically in medical costs. So we're talking about hospital costs, other institutional costs, costs in the outpatient setting, pharmaceuticals. And then sometimes, depending on whether we're doing cost effectiveness or cost utility, we might be interested in the costs that are borne by patients, including lost income. And then in other cases, if we're looking at, for example, mental health interventions or substance abuse, we might be interested in social costs. I mean, there might be costs to, for example, the criminal justice system that are important because the intervention reduces those significantly. Cost conceptually can be, economists think about cost as fixed versus variable. And, conceptually, we'd be more really interested in the variable cost. Fixed costs are generally considered to be sunk costs, and therefore you can ignore them. But the reality is, and this gets back to this point that I made about an hour and a half ago with regard to indirect or overhead, sometimes you can't ignore them because you can't separate them from your cost, from the data set that you have. There's no way to separate them. So as a result, average costs are in practice what most people use. And for example, if I were to get data from hospitals in the state of California, what I'd have is the average cost per hospital admission. That includes fixed and variable costs. So there's no way for me to separate out those two. Joint products, it may be that an organization is doing a lot of different things as part of an intervention, and it's hard to separate the intervention costs from the other things that are being done simultaneously. And so that's, you want to separate them if you can. In some cases, it's difficult to do. And then the question is, what's the time horizon for my study? In general, the rule of thumb is that you want to make sure that it's long enough to capture relevant health benefits. But, as one of the questions that came from LA Care indicates, if you're trying to improve health outcomes in your members, in order to do that, you might have to look for 30 or 40 years, and nobody has time to do that study. So then you have to look at, well, what are more proximal health outcomes, and you can measure changes in health behavior, and then say, well, that's important, and we'll infer that if those changes in health behavior can be maintained, that will translate down the road into better health outcomes. Where do we get the data? Sometimes you have to collect it yourself, and sometimes you can get it from administrative sources. If you're collecting it yourself, then you have to specify, and you need to do this in either case, specify sort of all of the relevant resources that are being used in an intervention or a treatment that you're assessing, and then try to measure the actual resources that are being used. So I will tell you that in some studies that I've done, we've had to develop basically a tool to count what is done for every patient, what tests they've received, what intervention, how much of the intervention they get, how much time is spent, say, with a staff person. So you're measuring it at really an individual level, and you have to develop an appropriate data collection tool. Now, you're not measuring the cost at that stage. What you're doing is counting, 15 minutes with this patient, 30 minutes with that patient, this battery of laboratory tests. You add all that up and then assign a dollar value. And that's the third step. And so when you're doing this kind of study where you actually have to collect the information and count the amount of resources used, you're imputing the cost by assigning a dollar value to all the things that were done. And And that brings me to the next topic, which is sort of gross costing versus micro costing. Gross costing allows you to use readily available data sources. So rather than follow a patient around, I might, if I were doing a study here at the hospital, I'd ask them to give me the full, basically the bill of services provided to a patient. So I am involved in a study. We're looking at copper touch surfaces in the ICU, whether those reduce infection rates. And that study finally has gotten underway. It's taken a while to get the right vendor to apply the copper touch to all the surfaces in the ICU beds. And it's randomized, so some beds have it and other beds don't. But we went live. So we're not going to follow patients around in that study, but what we will do is the hospital will supply us with a detailed record of all the care provided to the patients in the ICUs for the next 3 years, in the 2 that are in this study. That will save me a tremendous amount of work in our study team. It means that we'll know everything that happened to the patient in terms of a service and what the total cost of that patient's stay was. A micro-costing study, on the other hand, would involve our study team following patients and, again, sort of collecting information on everything that was done. And in this case, that's unnecessary. But in some cases, you might want and need to do that because there's very important variability that an administrative database doesn't capture. If your intervention depends on the amount of time spent with a patient, for example, you might want to actually measure that by following or asking, the study, the intervention team to track how much time they spent with a patient, if that really matters in your intervention. Where do you get the cost? Well, pharmaceuticals, you can use acquisition cost, cost of administering, monitoring, and compliance. There is pharmaceutical data available and price information available through several different sources. With hospitals, if you're looking at hospital data, you can do what I've described is basically called a time and motion study, following patients around. The other more common method is that costs are estimated from hospital charges using a ratio of costs to charges. There are literally hundreds of, and probably at this point thousands of studies of hospital care that have been done using RCCs. And it's simply because hospitals either don't really know the actual cost for an individual patient, or if they do, they're not willing to share the information. But they'll report charges to, say, a government agency, and then you have to make an adjustment. Another thing that you can do if you're working with hospital data is to impute the cost using something like Medicare DRG rates, where you assume that Medicare is basically paying the cost of care, and there's good data to support that Medicare is roughly paying the cost of care, so Medicare DRG payments are not a bad proxy for the cost of hospitalization. Oops. Physician cost data is very difficult to obtain. So the best we can do in most cases is look at payment data, and again, Medicare payment rates are a pretty good proxy. And in fact, most private insurers use Medicare payment rates, but pay a premium on top of Medicare. So in other words, they'll use the same rate structure, but pay something like 20 to 30% more per service. So if you have the Medicare payment information, you know that that's what a reasonable basis for what doctors are being paid. I've already mentioned family and social cost, and I'm running out of time, so skip over these. One question that often comes up in these studies is, how do I measure the fact that if I'm doing better and people are living longer, I'm saving lives, that means that people are going to use more health care. How do I measure those costs? This is a little bit of an obscure question, but I just thought I'd put it in here because it often comes up. The panel on cost effectiveness recommended a long time ago to ignore these costs. Their justification was they're unlikely to have a large impact. That may or may not be true. It really depends. I mean, the fact is that if you have an intervention in early childhood, then you're basically saying you're going to live your whole life now, and there are costs associated with that. But, conceptually, it's like, well, really, do we want to measure that? Because that's, a certain percentage of, if we save a child's life, a certain percentage of those kids, at some point as adults, something bad might happen, and it's going to cost society money. And do you really want to start trying to balance the fact that some kids are going to cost more later versus it just puts you in a kind of a position where you're making, again, morally kind of messy decisions. And so it's actually just safer to say we're going to forget about that. People are going to live longer. Some bad things are going to happen later. That doesn't mean we shouldn't save people now. And we'll forget about or not worry about the negative consequences of having a longer life expectancy. And so that's my talk, and I got through without rushing too much. So I realize that I've given you a lot of information today. I didn't want to say this at the beginning, but I hope that it's apparent now at the end. You've just gotten a very broad introduction. I went a little into the details, but I have no expectation that you can now go out and do a cost-effective study. It's a little too much to teach in even 3 hours, but hopefully I've given you a better understanding of why we do this work, why it's important, what some of the techniques are and what some of the assumptions are. I mentioned that medicine is, an art and a science, and cost-effectiveness studies are both an art and a science. There are a lot of assumptions that go into these models. They sometimes, and I'm an advocate for this work, I think that it's always better to have good data and to lay out your assumptions in a transparent fashion. But I also will acknowledge that sometimes these techniques have a veneer of precision because they're quantitative, and that may be not justified because they're only as good as the assumptions that go in. And you can put really bad assumptions into these models and they'll still crank out numbers for you. So, exactly. So, the techniques will produce numbers, but you really have to be cautious about what you put in and have good. But if you have good assumptions, good scientific evidence, and build these models based on defensible assumptions, then they produce pretty good information. Anyway, it's been a pleasure talking to you today and giving you an introduction to this. If you have questions, this is how to contact me at my email address. You can also call as well. I'm readily accessible by phone. So thanks very much.
Thank you.
Thank you.
Thanks.
Please fill out the evaluation when it comes in your email.
Must be a little anxious to be doing research that's constantly hostile.
Well, I will tell you that although I